Topics covered in your lectures till now: cleft, oral cancer, cyst, TMJ ankylosis. सब बोलोगे कैसे समझ आएगा? TMJ ankylosis left. बाकी सारा हो गया है. It is covered. And cleft नहीं हुआ है. cyst and tumors are done. Maxillofacial. Okay. So at least you'll have some idea what cleft palate is. Huh? Oral cancer भी पता होगा, cancer of the oral cavity, head and neck region. So basically these are the conditions that have either directly have a hard tissue defect, or the treatment, the management of these conditions lead to hard tissue defect. For example, cleft, patient has a cleft alveolus and cleft palate, right? So he has a hard tissue defect. Okay. Then we have micrognathia, the jaw is smaller. Now, first of all, the biggest issue is the aesthetics. The patient has a deformity called as bird faces, okay, because the face looks like a bird, okay, chota sa jaw hai. And because of this small jaw, the tongue falls back, there is obstruction because of the tongue in the airway, okay. So the patient will have obstructive sleep apnea. That is one. Then we have a different cysts and tumors that can lead to resorption of the bone, and the management of these diseases. In this case, this is a huge cyst, so we'll have to resect this and this part, okay. So there will be a huge defect in the mandible angle and the body region, right? After the management. In case of, this is what the defect will look like, okay. So traditionally we used to manage this condition with a recon plate, reconstruction plate. Then we have TMJ ankylosis. TMJ ankylosis pata hoga, there is a fusion of the condylar head and the glenoid fossa. So we'll have to, and because of that, there is impaired growth of the mandible on one side, on the affected side, and the mouth opening is reduced. So the management of TMJ ankylosis is gap arthroplasty. So we have cut this condyle, we have created a huge gap so that the mandible can move freely, right? But because of the management of TMJ ankylosis, we have this defect. And when the patient opens mouth, the patient has deviation on the same side, the side where the surgery was performed, right? So this was my patient. You can see the mouth opening difference. Anyways, so then we have orthognathic surgery. What are the available management after this? One is orthognathic surgery to manage the hard tissue defect, okay, bone defects. In this we can perform bilateral sagittal split osteotomy. Depending on the deformity, depending on the deficiency, we can go for bilateral sagittal split osteotomy, genioplasty, or Lefort 1 osteotomy and advancement. Okay. But the issue with orthognathic surgery is we just cut the bone and we move it forward. Now this bone is attached to the soft tissue surrounding it, right? Muscles, ligaments, they are attached to it. So these ligaments, these soft tissues, they are going to prevent the too much movement of these bony segments, right? So maximum movement of movement that can take place in this BSSO, for example, it is 1 centimeter maximum. Okay. If you want to, sorry, if you want to move the distal segment, this segment, beyond 1 centimeter, you'll have to remove the attachment of all the ligaments and the muscles, okay. But that is further going to hamper the blood supply of this segment, and that might lead to necrosis, okay. So it has different advantages and disadvantages. Then we have bilateral sagittal, not bilateral, Lefort 1 osteotomy. Okay, we just cut the maxilla at the Lefort 1 level and we advance it and we fix it using the plates, okay. Another option is bone grafts. In bone grafts, we can go for autografts, the grafts taken from the patient's own body, or we can go for allograft, graft taken from the same species. Okay, दूसरे बंदे के body से लिया. If suppose the patient is dead, okay, before the biological death occurs, we take the the bone tissue from that body and graft it in the patient's body. Okay. Now, autogenous disadvantage is that there will be another surgical site. Okay. उसका pain swelling रहेगा patient को, that is another disadvantage. Allograft में as the graft is taken from outside the body, the patient might have reaction with the graft, the body might reject the graft, okay. The same goes with the synthetic grafts. So all these techniques, they have some disadvantages, and add to that, if we want to move, we want a gain of more than 1 centimeter bone, that is going to be difficult with these two things, okay. So we have another option called as distraction osteogenesis, and that's what we are going to talk about today, okay. Any idea what distraction osteogenesis is? No? Chalo, main batata. So basically distraction, the word distraction comes from the word distract, and that comes from the word dis and trahere. These are Latin words. Dis is apart and trahere is to drag. So distraction means to drag apart, and osteogenesis, formation of new bone. So distraction osteogenesis means formation of the new bone by dragging apart bone segments, okay. I'll show you how it happens, how new bone formation occurs. So, do you know what this image shows? ये क्या हो रहा है? So, at least in the older days, what used to happen is fracture हुआ because of the muscle pull. These fracture segments, they are overlapped. So, to counter the muscle pull and to keep the fracture segment aligned properly, what they used to do is they used to use a pulley system and attach a weight here. उसको खींच के रखता था, okay. But in some patients where slightly more weight was used, they saw there is expansion of the bone. Okay, once the healing has occurred, they saw that there is gain of some amount of bone in the length of the bone. So the surgeons were pretty happy about the result, that they found a new method to gain some amount of bone. But the patient was not very happy, of course. एक टांग लंबी हो गई है. Okay, so after that, many surgeons, they tried to recreate this effect with variable success, okay. So Cordwell, ये सारा लिखना है, लिखो history है, it's not that important. But, not that. So Kazanjian and Stader, they tried to perform this procedure in a maxillofacial region, mandible and maxilla, okay. But all these people, they had a variable rate of success because they didn't have any fixed protocol, fixed rules to follow, okay. So, सबके अलग-अलग techniques थे. Some had variable success rate, some had failure because of infection, too much of a distraction, so thinning of bone was there. Some, the rate of distraction was slow. So because of that, before gaining the actual desirable length of the bone, ossification occurred. ये सारी चीजें मैं आगे समझाऊंगा. But all these things occurred, and they had variable success rate. So in the year 1950, a Russian orthopedic surgeon called as Gavril Lizarov, he performed multiple studies, performed different surgeries, and he gave a fixed set of rules, okay. And these rules, they have been followed till date, and the success rate is very high in these cases. So what did he say? He said that first of all, we need to maintain as much blood supply to the bone as possible. So if you know, to any bone, there are two blood supplies, okay. One is centrifugal, one is centripetal. Centrifugal is that the blood vessel is inside the bone and it is giving out the blood vessel, the capillaries. For example, in mandible, inferior alveolar artery and veins, right? अंदर से blood supply आ रही है. Then we have centripetal blood supply, that is from the surrounding area. So in case of mandible, we have the mucoperiosteum. So the mandible is also getting the supply from the mucoperiosteum. Okay. So mandible has two blood supplies. One is inferior alveolar neurovascular bundle and the periosteum. Okay. So if we want to expose the bone, we'll have to reflect the periosteum, and that is going to hamper the blood supply. So what he said, in any case, in any bone, he said that you have to perform minimal periosteal stripping. जितना जरूरत है उतना ही, excess नहीं करना है. Try to preserve the periosteum, because once you strip the periosteum, you separate the periosteum from the bone, you're going to hamper the blood supply. That is the centripetal blood supply. Okay. And he used a ring system. So let me show you. So what happens is he used this ring system, and इनके बीच में they were connected with the screws. Okay. So when we rotate these screws, these rings are pushed apart from each other. So the movement of these rings and the direction of these rings, it was in a controlled fashion. So using these two things, he was able to achieve a high success rate. So using this technique, you can see the patient was able to gain a normal length of the bone. Okay. Now, another thing before we start with the maxillofacial head and maxillofacial distraction. Now you see this. This is a tumor of a lower jaw mandible region, anterior mandible. So, do you think this soft tissue was always there? This much soft tissue was always there? No, right? The tumor started expanding slowly and gradually. It applied pressure, the tensile pressure. Tensile pressure क्या होता है? Tensile force क्या होता है? Stretching force is there. Okay. So, this tumor applied stretching force over the soft tissue surrounding soft tissue. Okay. So, because of this stimulation from the tensile pressure, okay, the generation of new soft tissue occurred, right? This phenomena is called as mechanotransduction. I forgot to mention mechanotransduction. Okay, so there is generation of a new soft tissue because of the tensile force. Okay, so we are going to use these two things, that is Elizarov's principle, okay, and this mechanotransduction to achieve optimal growth. Yeah, another thing I forgot to mention, in bilateral sagittal split osteotomy, I told you that the bone is attached to the surrounding soft tissue, and those soft tissue are preventing movement of the bony segment, right? Now in this procedure, if we apply, sorry, using the distractor devices, we apply continuous but low grade pressure, okay, continuous low grade pressure there. So what will happen, because of mechanotransduction, the soft tissue is also going to grow. Okay, now the soft tissue is not preventing the growth, the forward movement of the bone. Okay, it is growing along with the bone. Okay, so that is another advantage that we have soft tissue generation also along with the bone regeneration. समझ आया? So in maxillofacial region, we have multiple applications. I'll show you first the results of the distraction osteogenesis in the maxillofacial region. The most common is the alveolar distraction. We just use a distractor device and we perform the osteotomy. This osteotomy in the alveolar bone, and we pull it up, okay, slowly and gradually. So we are able to achieve the alveolar bone height. In case of mandibular micrognathia, you can see the mandible is cut and pulled forward. So the patient's facial appearance improves and the tongue is pulled forward along with the mandible, right? So because of that, obstructive sleep apnea is also cured. Okay? The same thing. In this patient, the patient was growing. Okay, there were growth spurts left. So what they did was, they overcorrected the defect. Jitna chahiye tha na, ideally at this point, they overcorrected it. So when the patient grew, maxilla also grew, and once the maxilla and the other soft tissue grew, so the mandible came into proper position. Okay. So if the patient is growing and you want to perform distraction osteogenesis procedure on the patient, you have to overcorrect the defect so that as the patient grows, the defect comes into normal position. The mandible, the bone comes into normal position. This is a case of a newborn infant. Okay. So again, so we come to the bone healing part. I won't go into the details, just remember, when there is fracture of any bone, okay, there is clot formation, then clot gets converted into fibrous fibrocallus, and that fibrocallus gets converted into bony callus, and this bony callus is remodeled over a period of 1 to 2 years, and final bone formation is there. Okay, bone maturation is there. So our aim is to stop this procedure, this healing process at this level, fibrocallus formation. Okay. Why? Because fibrocallus is slightly stretchable. You can mold it first of all, and there is neoangiogenesis going on. Neoangiogenesis means in the clot there is new arteries and veins formation is there. Okay, neoangiogenesis. Okay, new blood vessels are formed in this region. Okay, this is the process, the bone healing process, and we want to stop this process in this level, fibrocallus formation, and we want to expand this. We will talk about this. So Elizarov gave these principles. First, the osteotomy, as I told you that we have to perform the osteotomy with minimal periosteal stripping. We have to make sure that there is minimal hampering of the blood supply. Okay, that is the first thing. Now, then we have latency period. Latency period is, इसमें हमें कुछ नहीं करना है, we just fix the bone after fracturing. Okay, fracture करने के बाद we fix the bone and we let the clot formation occur and we let the fibrocallus formation to occur. Okay, and this in head and neck region, the fibrocallus formation occurs within 5 to 7 days. Okay, so the latency period is going to be 5 to 7 days in the maxillofacial region, especially. So once once the latency period is over, we are going to start stretching the fibrocallus. Okay. लिख रहे हो अभी भी? Okay. We cut the bone with minimal periosteal stripping. Then we wait for a few days. Okay. Then once the latency period is over, then we start with distraction process. Distraction process means there are two things. One is the rate of distraction. Rate of distraction means the amount of the movement of the segments. Okay, the amount of movement of the segment that occurs in one day. Okay, एक दिन में हम कितना pull कर रहे हैं. Okay. So you know what? बाद में explain करूँगा. I'll just show you the photos, short photos. So we perform the osteotomy. We cut the bone. We let the fibrocallus formation to occur in the latency period. Then once the latency period is over, we start pulling the bony segments away from each other. Okay. Now इसमें क्या होता है ना? Now there is new angiogenesis in the fibrocallus formation stage, latency period. ठीक है? So once we pull the segments slightly apart, तो क्या होगा? There is micro trauma to all the fibrocallus region. Okay. So वहाँ पे भी there will be some bleeding. समझ आ रहा है? So if we start pulling this apart, okay, there will be micro trauma. Micro trauma होगा वहाँ पे bleeding, there will be bleeding. And the healing process starts again, zero से start होगा. So we are keeping this fibrocallus stage in the healing process continuously. As long as we keep stretching it, it is going to stay in the healing phase, fibrocallus stage. समझ आया? Fibrocallus है, it is slightly stretchable. We pull it, so the blood vessels, they get damaged, they get torn. So there is more bleeding in the area, there is more inflammation, there is clot formation, and there is fibrocallus formation. Again we pull it, again healing occurs. Okay. So we have the distraction part. We pull it to the desired length. Okay. Once we have achieved the desired length. Okay. Now remember, this is still in the fibrocallus stage. Now we want it. Once we have achieved the desired length, now we want the healing process to continue to the consolidation phase. We want the fibrocallus to convert into bony callus. So what we are going to do? कोई भी fracture को heal होने के लिए what we do is we prevent any movement. So what we are going to do is for a period of 6 to 8 weeks. We are going to, not 6 to 8, 8 to 12 weeks, we are going to fix it. ये दोनों segment, after achieving the desired length, we are going to fix the two segments. They are not going to move. And once there is no mobility, so this is going to get converted into bony callus. Fibrocallus से bony callus में convert हो जाएगा. Okay? And how are we going to know that there is bony callus formation? We are going to take regular radiographs of the patient. Okay? Radiograph में you will start seeing slightly ossification of the bone. Of the fibrocallus. Once you start seeing the first appearance of ossification, that's when you know that the consolidation has started. Okay, then you can remove the distraction device, and once the ossification has occurred, there will be remodeling of the bone over a longer period of time. Okay, जितना force लगेगा उतना ज़्यादा remodeling होगा bone का. Okay, so in short, these are the principles and the steps given by lizarov for distraction osteogenesis. Okay, so in this you can see at the 0 week after the fibrocallus formation, at the initial stage you don't see any fibrocallus bony callus formation, but as you take on multiple radiographs, you start seeing the ossification of the bone, right? Okay. So this was consolidation. Now we'll talk about all these steps in the mandible. So we have the mandible, we perform minimal periosteal stripping, especially if we want to cut the mandible. What we are going to do is we are going to strip only the minimal areas wherever you want to give the cut, osteotomy cut. Suppose we want to give a cut in this region, we are going to strip the surrounding area only, and the lingual side पे तो बिल्कुल भी stripping नहीं करेंगे. We strip the mucoperiosteum only on the buccal aspect, and उसको भी minimal strip करके we perform the cut. From the buccal side, we cut the bone through and through. Okay, of course, we'll try to preserve the nerve. we have to make sure that nerve is not being cut, not damaged. वरना patient को nerve injury से बहुत सारे symptoms होते हैं, if you remember the previous lectures, right? So we have to preserve the nerve. So we gave a osteotomy cut. Now after the osteotomy cut is done, there will be bleeding and clot formation. Okay. Now after the once the clot formation has occurred and there is fibrocallus formation, during the latency period, we start pulling the mandible forward. Okay. Now you can see this is the red part, this is the fibrocallus. As we stretch, there is generation of the new bone. This red part indicates new bone formation, fibrocallus. Now once we have achieved the desired length, we are going to fix the area, fix the two segments, and that is going to consolidate into osteocallus, bony callus. Okay. So this is how you achieve the new bone formation. Okay. Now remember this, as I told you earlier, there is also stretching of the soft tissue. Soft tissue is also generated. Okay. जो भी length है, even the length of the attached soft tissue is going to increase. Okay. That is the advantage of this. And how is the soft tissue generated? The process, the name is mechanotransduction. Okay. So this was consolidation. Now we come to the osteotomy. We'll talk about this in detail now. Now how do we select the site of the osteotomy? Suppose we have a mandible that is deficient in the height in different parts. Okay. So wherever we give a cut and we pull, जहाँ से भी cut देंगे, that is going to dictate how much bone we are going to get. Okay. So if we give a cut in this region and we pull it, so the height of the bone is similar to the osteotomy site, right? So if you want to achieve a higher bone height, you will have to make sure that you have given the osteotomy at a site where there is more bone. Okay. So in this case, we didn't give the osteotomy cut at this side, we gave it slightly anterior, just posterior to the mental foramen. So now when we perform distraction osteogenesis in this region, we are going to get more bone, right? Now this doesn't only apply at the height, thickness भी ज़्यादा होगी तो thickness ज़्यादा मिलेगी bone की, right? समझ आ रहा है? It's very simple. So this was, now you can compare the two, the amount of bone that you are getting in the two methods. Okay, the two different sites of osteotomy. Okay. Also, no, that is fine. Okay, then we come to the latency period. Now, latency period depends on the blood supply of the bone. If the blood supply is hampered, you'll have to wait for a longer duration for the fibrocallus to form. Okay, come bleeding, if the blood supply is less, the healing will be hampered. Healing will take a longer time. So that is why we'll have to wait for a longer duration for the fibrous callus to form. Okay. An example of a hampered blood supply is for example, the patient who has undergone a surgery for CA of the mandible, cancer of the mandible, carcinoma mandible. So after the surgical resection of the mandible, patient is going to undergo radiation therapy, right? So radiation therapy में क्या होता है? The blood supply is hampered, है ना? So first of all, you will have to wait for a longer duration in such patients. That is one. In a normal individual, 5 to 7 days is enough for a latency period, whereas in a patient who has irradiation therapy, so in such patient the duration is 7 to 10 days. Okay. Another thing, a young individual, a young patient is going to have a faster healing, है ना? So in such patient the latency period is shortened because the healing is faster. So if we wait for a longer duration, 7 दिन तक wait किया, so fibrocallus तो form हो गया, the process of bony callus formation has started. So the period for latency period reduces. Okay. So we have to make sure, we have to keep in mind the age of the patient, medical history of the patient. Okay. So in young individuals the healing is faster, so the latency period is 3 to 5 days. Whereas in normal adults who doesn't have any relevant medical history, blood supply is fine. In the adults, the latency period is 5 to 7 days. And as I mentioned earlier, in case of patient with hampered blood supply, for example, CA patient जिनमें radiation therapy हुआ है, the latency period is 7 to 10 days. Now, even in those patients, make sure the patient first undergoes the hyperbaric oxygen therapy. Okay, ये osteoradionecrosis हुआ है, osteomyelitis में हुआ होगा ना, सर ने पढ़ाया होगा. So there is something called as hyperbaric oxygen therapy that increases the blood supply of the bone. Okay, after radiation therapy. So make sure the patient undergoes that first, and then we have to start with the distraction process. Okay. Now, latency period also depends on the size of the bone. For example, the alveolar bone, it is very thin, patli si hai. So in that case, we are going to wait for a longer duration because that is going to get blood supply only from the periosteum. Okay, हमने उसको cut कर दिया तो अंदर की जो centrifugal blood supply, that is hampered one, and the size is smaller. So that is going to increase the latency period. Another thing, the same thing as I told you, the duration is longer in alveolar distraction. Now suppose we have something, okay, yeah. So now we come to the next part, that is distraction phase. Distraction mein there are two things, as I mentioned earlier, rate and rhythm. Rate is the amount of distraction done in one day, 24 hours, okay. Ideally, it is 1 mm per day, okay, in a normal individual. And the rhythm is कि कितनी बार में we split the 1 mm, okay. So either we have the option of performing 1 mm stretching at a single go, एक ही बार में 1 mm stretch करो, but that is going to hamper the fibrocallus, okay. So what we do is we divide this into 2 or 4 parts. Usually it is 0.5 twice a day, morning and evening, 0.5 mm in the morning, 0.5 in the 0.5 in morning, 0.5 in evening, okay. If you can go for 0.25 4 times a day. That is better. In fact, usse bhi better hai that we give 1 mm continuously in 24 hours. Now watch this. थक जाओगे देख के. Now this is continuous. एक ही बार में बस continuous pressure दे रहे हैं. Slowly and gradually we are pulling it. We are not stopping. 0.25 करके रुक नहीं रहे हैं. We just keeping it, pulling it. Okay. So that is the most ideal rhythm. Continuous. But this is this is not possible manually. First of all, you can't sit the whole day. The doctor can't sit the whole day and keep on activating the distractor device. Okay. That is why we divide it into parts, which is this. Okay. क्या हो गया? One second. Oh, okay, it's here. So, previous was continuous. Then we have intermittent. As I told you earlier, we give 0.25 4 times a day or 0.5 twice a day. Okay, we divide it. Okay, so you can see it is stretched and then wait for a few time for some time, and then again it is stretched. Then we wait, then again we stretch it. Okay, so this is intermittent. So this is what is usually followed. Okay, ideal is continuous, but that is not manually possible. Okay, that is why we follow this. Now another thing is I'll show you the distractor devices, don't worry. When we, in case of mandible, suppose, mandible body may we perform distraction. Okay, so the distractor device is pulling both the bony segments apart from each other, right? So this segment is pushed forward, but this is also pushing backward. This is also the proximal segment is being pushed backward. Now the patient, if we perform 0.25 suppose, and the patient complains of pain in preauricular region. Why will the patient have pain in preauricular region? This is being pushed backward. The condyle is going to apply pressure over the glenoid fossa, the posterior surface, right? Because of that, agar patient ko pain ho raha hai, then you can divide this into 0.25 4 times a day, okay? Depending on the patient's comfort. So, what is this? Yeah, another thing, the rate. As I told you, ideal rate is 1 mm per day in maxillofacial region, okay? Suppose the doctor is a little impatient. He starts applying pressure on the traction of 3 mm per day. The problem is whenever we try to stretch something at a faster rate, बीच में से thin हो जाता है, right? So when we start applying more, we use more rate of distraction. The amount of distraction is more than 1 mm. It is going to lead to thinning of the callus. Okay. So if we allow it to convert into bony callus, क्या होगा? You will have a thin bone. Okay, that is the disadvantage of a faster rate of distraction. Now, The problem here is if we apply a slower rate of distraction, क्या होगा? As I told you, there is fibrocallus, and that fibrocallus is going to get converted into bony callus, right? So if our distraction process, if our rate of distraction is less, suppose if we go for 0.5 mm per day, okay, what happens is the fibrocallus starts getting converted into bony callus. Okay, it is not being kept active all the time. It is getting time to get converted into bony callus. So क्या होगा? It starts getting converted into bony callus. So we are not able to achieve the desired length जहाँ तक हमें pull करना था, because it gets converted into bony callus. जितना हमें length चाहिए था उससे पहले it gets hard. Okay, so we're not able to pull it properly. So the disadvantage with faster, higher rate of distraction is that there will be thinning of fibrocallus. Slower rate of distraction, there will be early ossification of the fibrocallus. It will get converted into bony callus, right? समझ आया इतना? I hope समझ आया होगा. Now, suppose if we modify the osteotomy site, for example, do you know bilateral sagittal split osteotomy? Orthognathic में सुना है? I'll show you the photo. So you can see the photo in bilateral sagittal split osteotomy as I showed you in the earlier photos. This is the cut. So the segments are overlapping over each other. Okay. Now in this we can achieve a higher rate of distraction because the segments are overlapping. So there won't be any thinning of the callus क्योंकि ये overlap हो रहे हैं. So in this case, if we perform the osteotomy in shape of BSSO, we perform the BSSO osteotomy, then we can keep the distraction rate to 2 mm per day. Okay. And the rhythm will be 0.5 4 times a day. समझ आया? So let's see. कहाँ गया? So this is the osteotomy site BSSO. You can see the segments are overlapping the mesial and distal segments, and the red part denotes the clot formation. Okay, and the cut is extended just distal to the mandibuloforamen. समझ आया? समझ आया? Okay. So this was BSSO osteotomy. How it is going to dictate the rate of distraction. Then we come to something called as dancing distraction. So suppose there is the patient has some defect, developmental defect, and because of that there is the requirement of distraction on both the sides, but on one side the defect is a little more. So एक side the distraction, the correction is required on both the sides, but on one side higher amount of correction is required. So how do we do that? For example, this patient, now you can see the length of the mandible, it is shorter than normal, right? But it is way shorter on the right side. समझ आया? So we are going to perform distraction on both the sides, but we need to keep this, I'll show you first. So what we're going to do is we're going to give the cut on both the sides, osteotomy cut, and we're going to get a clot formation. Once we wait for the latency period, we start performing distraction on both the sides. Okay? So what happens here is, on right side we give the distraction force continuously, whereas on this side you will see now. One second, I'll pause this. I'll show you the video directly. Okay, so let's stop. So up to this point, यहाँ पे भले equal नहीं दिख रहा है, but we perform equal distraction on both the side up to this point. Okay, जहाँ तक left side पे हमें distraction करना है, up till that length we are going to perform the distraction equally on both the side. But after this point, we don't want the distraction to occur on left side. We just want the distraction to occur on the right side. But the problem is, suppose we stop the distraction on this side and we continue distraction on this side. क्या होगा? There will be ossification of this side, right? We're not moving this. So because there is ossification on the left side, it is going to prevent movement on the right side also. Left side पूरा hard हो गया, it won't rotate, right? So what we do is we keep it activated. कैसे? After this point, we are going to activate it 1 mm. Next day we are going to reduce the length 1 mm. Again the next day we are going to increase the length 1 mm. Again we are going to decrease 1 mm. समझे? Increase कर रहे हैं on one day, alternative day पे we are decreasing. So we are keeping it activated. So this is called a dancing. Dancing? Okay. So this is called a dancing distraction. So up to the required जहाँ पे भी मिनिमम डिस्ट्रैक्शन चाहिए वहाँ पे वी कंटिन्यू द डिस्ट्रैक्शन ऑन बोथ द साइड and then we start with the dancing distraction on one side. Now if you see this is going, you're going to see we increase, we decrease, we increase, we decrease the length. Okay, whereas this side distraction was continuous. Again I'll show you. So again if you see, we increase the length of the distraction, we again decrease the length, we again increase, we again decrease, whereas this continues until we achieve the symmetry on both the sides. समझ आया इतना? Let's close this. Okay, this was your dancing distraction. Now this is the lateral view of the same thing. Okay, so animations इतने अच्छे नहीं है. I didn't have enough time. मैंने कल ही preparation start किया था. So you can see dancing starts increasing, decreasing, increasing, decreasing, and on the other side there is continuous distraction. Okay, and we achieve the symmetry and we achieve the length on both the sides. Okay, this was dancing distraction. Now we come to the distractor devices. This is an intraoral distractor device. Okay, so using these holes, the distractor device is attached to both the segments. Okay, so if you view this video, you can see when we activate, we rotate the knob. Okay, this is pushed apart from each other. You can see that. So we can control the movement of the distractor device. Okay, so if we attach the two segments on both the ends, we are going to push the segments apart from each other, 1 mm, 0.5 mm, 0.25 mm depending on the requirement. Okay, so this is what the distractor looks like in place on the mandible. Okay, understood? So we have the distractor device. These are this is the distractor device used in the maxilla. So depending on the side, there will be different design and configuration of the distractor device. Okay. So if you see, it is activated by a screwdriver. This screwdriver is pushed into this end and it is rotated. So usse it is pulled apart. Okay. So you can see this part is attached to fixed to the zygomatic bone, whereas this part is fixed to the maxillary bone. This is used in the Leaford 1 osteotomy and forward movement of the maxilla. Okay. So this was your maxillary distractor device. Okay. Then we have something called as high-rack distractor. It is a tooth bone and a bone, so called as hybrid distractor. It is activated by a wrench. So अलग-अलग devices के अलग-अलग activators होते हैं. Then we have this tooth bone distractor device. We cut the bone surrounding the tooth and we pull it downwards. Okay. Now classification of the distractors. Now based on the location of distractor, whether it is the main distractor device, whether it is placed inside the soft tissue or outside, based on that it is classified as internal. You can see the main distractor device जहाँ पे movement हो रहा है, that is inside the soft tissue, that is internal distractor device. This is also an example of internal distractor device. Then we have external distractor. So we have the pin fixation on the bone, okay, but the main distractor that is causing the movement is outside the soft tissue. Okay, समझ आया इतना? So this is the external distractor device. This is the external distractor device in place. So the problem, this is the halo frame, halo distractor device, and this is used to pull the maxilla forward. Now the problem with this is, give me two pen. Pen do. Ye de. So we use pin fixation in these cases. Okay. The advantage here is, suppose we have a pin fixator. Okay, distractor यहाँ पे. Now we apply pressure, but do you think when we apply pressure, अगर हम 5 mm का movement कर रहे हैं, we are going to get the 5 mm movement here? No, because of the length, right? So in external distractors, in the external distractors, we are not going to get the same length as we are giving the distraction forces. Okay. Also, because of these forces, the chances of pin loosening, ये जो pins हैं, they might loosen. Okay, it's like a pole in the ground. उसको जितना movement दोगे, it will get loose, right? Same thing goes here. So the amount of distraction is not same as the activation of the distractor device, and it might lead to loosening of the pins. Okay, that is a disadvantage of external distractor. So we come to the internal distractors. Internal distractors can be classified as extraoral and intraoral. Now extraoral, how do we classify, how do we differentiate? ये जो activation arm है, Okay, this activation arm, wherever this activation arm is present, that is going to dictate the classification as intraoral or extraoral. So in this case, you can see that the distractor is fixed on the bone inside the soft tissue, but the arm is outside. So we are going to activate the distractor using this arm. Okay, so this is extraoral distractor, extraoral internal type distractor, whereas this is the intraoral distractor because the activation arms are present intraorally. Okay, again another example of intraoral, internal distractor. Okay, then internal distractors can be further classified based on where they are attached, okay, where they are fixed. So they can be tooth bone, you can see hyrax expansion, this is rapid maxillary expansion device. So these are tooth bone distractors. Then we have bone distractors, they are attached to the bone, okay. Then we have hybrid that are attached to both bone and the teeth, okay. Now the problem, the most preferable here is hybrid. Okay, why? Because in bone and tooth bone there might be a V-shaped deformity. When these expand, ये expand करेगा, this is going to cause expansion at the lower border. But because of the mylohyoid muscle, they are going to pull the inferior border inside. So this is going to expand. Okay, so anteriorly you are going to see a V-shaped deformity. So that is why we prefer to use hybrid distractors because it is not going to allow the V-shaped deformity. समझ आया? So, now we come to the techniques. There are different types of techniques depending on the number of sites where new bone formation occurs. Okay, so abhi tak jo aapne dekha, that was monofocal. Bone formation occurs only at one site. Okay, we just perform the osteotomy and we pull the two segments apart. So that is monofocal. There is only one site where there is new bone formation. Okay, then we have bifocal. This is the example of monofocal. Okay, we just pull the segments apart. Then we have bifocal. This is another example of this is another example of monofocal. Now we have something called as bifocal. Suppose the gap is a little more. Okay, there was a resection of the body of the mandible, for example. So उसमें कैसे achieve करें? So what we do, proximal segment पे we cut a small disc. इतना छोटा सा segment we cut, and then we allow it to heal, and then we start pulling it. Okay, so we are closing the gap like this. समझ आ रहा है? So we create a disc, that is the name of this disc is called as transport disc, because we are going to transport the disc from the proximal segment to the distal segment. This is the proximal, this is the distal segment. So we transport the disc from the proximal to the distal segment. Now इसके बीच में we have the fibrocallus formation, right? So यहाँ पे तो bone form हो रहा है, but as this reaches this end, okay, remember this, ये जो end है ना, let me show it here. One second. Okay, so this end, okay, as this moves forward, yeah, I forgot to mention another thing. So if there is total resection of the mandibular body region, okay, so soft tissue भी वहाँ पे नहीं होगा, okay. So when we push the transport disc forward, along with the transport disc, there is fibrocallus formation. Also, the overlying soft tissue is being stretched and regenerated. More soft tissue is also generated, right? So once the disc, the transport disc reaches the final site, okay, as it moves forward, by the time it reaches this end, it gets covered by a fibrocartilaginous structure. Okay, this end, the distal end of this transport disc, it is covered by a cartilaginous structure. Okay, so if it reaches the final site, it is not going to fuse with the distal bone, distal segment, right? So what we are going to do is another procedure where we are going to cut this end and we are going to graft the site. Okay, so we are going to get two sites where we have bone formation. One is using the distraction, other side we are going to graft the site. Okay, so we have two sites of bone formation, that is why it is called as bifocal. Now suppose in a this is a case of bifocal. Okay, for example, the defect is a little more, it can't be managed with only one transport disc. So what we do is we create two transport discs, one on distal and one on proximal segment. Okay, दोनों को move करते हैं. Okay, so both are moved towards each other. So we have bone formation on this side, bone formation on this side. Okay, and these ends are covered by cartilage. So we expose it, we cut them, and then we graft this site. Okay, so we have three sites of bone formation, that is trifocal. सो अब समझ आ रहा होगा टेट्राफोकल में क्या होगा, और ज्यादा डिफेक्ट है. सो ऑन वन साइड वी क्रिएट 2 ट्रांसपोर्ट डिस्क्स. ओके, अब ऐसा नहीं है दोनों 60 में मूव करते हैं. सो व्हाट वी डू इज वी टेक अ लार्जर सेगमेंट ऑन वन साइड, वी मूव बोथ देम, एक साइड से मूव करेंगे, ये साइड पे भी मूव करेंगे. Once this is moved to the maximum length, जहां तक जा सकता है, then we fix this part. We split the bigger segment and we split it into 2 parts. So one end is attached to this side and जो दूसरा segment है we move it towards the other segment. So we have 4 sides of bone formation. Okay, understood? So we have 4 sides of bone formation. Depending on the bone formation, टाइम हो गया है, 5 मिनट बचे हैं ना, तो जल्दी जल्दी करते हैं या फिर नेक्स्ट टाइम करेंगे, है ना? हाँ, नेक्स्ट टाइम ना, चलो ठीक है.